to hear from. So our topic today is going to be big data in primary care. And of course, I could spend the next 2 hours trying to discuss what big data is, but I'm hoping our panelists can shed some light on that. And they're going to talk about how they've been using different data in primary care research. And this is in Alberta. And they will be focusing on different conditions. And today we have with us Dr. Stephanie Garris, who is the Assistant Director of the Southern Alberta Primary Care Research Network. And I'll let her introduce herself. She'll be the main speaker. But we also have 3 other panelists with us. We have Matt Taylor, who is a data manager with the Canadian Primary Care Sentinel Surveillance Network at the University of Alberta. Matt, that's in Edmonton, correct?
That's right.
Yeah, there you go. Then we also have Dr. Paul Ronxley, who is an Associate Professor of Community and Health Services at the University of Calgary. And for those of you who aren't Westerners, I hope you appreciate that we've brought people from 2 very competitive cities who typically don't get along. So this just shows you how great the people from primary care are, that we're willing to combine forces from Alberta and Edmonton. And last but certainly not least, we have our patient partner, Jill Bernhardt, and she is a panel member on the Alberta Primary and Integrated Healthcare Innovations Network's Families panel member. I thought I had a lot of things to remember with picking, but Jill's got even more. And she will be sharing some of her experiences with us as well. So those are our panelists. I'd like to talk to you about a few things that are specific to attending a webinar on Zoom that you may not have seen before. First, on the bottom of your screen is a chat button. You should know that we can't see or hear you, although you can see and hear us as panelists and speakers. So there's a chat button there. And when you click on the chat, a button will pop out to the side, and you can either direct comments only to the panelists by selecting all panelists, or if you click on that where it says all panelists at the bottom, you can select all panelists and attendees, and this will let you share general comments. When you have questions for the panelists, if you move along the bottom of your screen, you will see 2 call-out boxes, and it says Q&A underneath them. When you click on that and you type a question there, all of the panelists can see it. I'll be using those questions and reading them out loud for our panel members to answer. You can either make your questions anonymous or leave your name there, but know that only the panelists will see it. If you leave your name there, I will acknowledge you when I'm asking your question. But do be aware that I will be reading out loud the questions because other audience members will not be able to see them. So that's how we will do the Q&A session after our panelists are all done talking. This session will be recorded. So please feel free to ask your questions anonymously or however you are comfortable. The other thing, s'il y a des personnes sur la ligne qui est plus à l'aise en français, plus confortable pour demander des questions en français, c'est moi qui va faire une traduction en anglais. Et si jamais il y a quelque chose, vous pouvez toujours faire un petit message à moi en français et je vais répondre à ce message. So please feel comfortable to ask your questions in French or English, although this presentation will be in English and questions will be answered in English. Finally, I would, at the end of the session, I will draw your attention to where you can find a recording of this session, the survey we'll be administrating, when our next session is, and to thank our organizers and funders. So before we begin, it looks like we've got a good crowd of people on the line. I would like to read a statement of acknowledgement of traditional land that was produced by the College of Family Physicians Indigenous Health Working Group. So we acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. We recognize that the many injustices experienced by the Indigenous people of what we now call Canada continue to affect their health and well-being. We respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all attendees to reflect on the territories you're calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship and contributing to reconciliation. So with that, I am going to stop speaking and let our first panelist of today, Dr. Stephanie Garris, take over. Our other panel members will be shutting off their videos until it's their turn to talk, and we'll be muted. Stephanie, if you want to go ahead and share your screen, I look forward to hearing what you have to say.
Okay, there we go. Well, hello everyone. I'm very pleased to have this opportunity to talk to you a little bit about health data in Alberta as part of the PIHCI Summer Learning Series. So I'm Stephanie. I'm the Assistant Director right now for the Southern Alberta Primary Care Research Network, which also hosts the Canadian Primary Care Sentinel Surveillance Network, which I'll provide more information about as we go. My background is in public health, and I also just recently finished my PhD in epidemiology last month. There we go. So I have no disclosures or conflicts of interest to declare. Okay, so there are a few different types of health data in our province. I'll go through a couple of examples here, but just note that this might not cover all sources of health data in Alberta. So I'll first start with administrative data. So administrative data are created from the process of administering healthcare. And these data are really valuable because they usually consist of almost all patients or encounters within the entire healthcare system. So for example, when you are discharged from the hospital, a discharge summary is created about your stay. And this makes up the discharge abstract database, which is one of the main administrative health databases. There are other admin databases that contain information on emergency department visits, physician billing claims, and pharmacy records for medications that are dispensed in community pharmacies. So the process for accessing administrative data is fairly straightforward once you have research ethics approval, and this is facilitated by Alberta Health Services in our province. We also have the Alberta SPORE support unit, and SPORE is the Strategies for Patient-Oriented Research. This support unit also has services that can help with accessing admin data for research, and they also have methodological support for projects that use admin data. So that's the data platform and the methods platform. So we also have national surveys that exist and can be used for research purposes. Things like the Canadian Community Health Survey or the Canadian Health Measures Survey. There are even regional surveys that generate information about health, like Alberta's Tomorrow Project. Surveys tend to only include a sample of all citizens, but they're great for getting really detailed information focused on a specific topic or research question. However, usually, but not always, but usually surveys tend to be cross-sectional, which means that you're not necessarily able to follow up respondents over time. And the last source that I'll be discussing in more detail today is data from electronic medical records or electronic health records. And so the acronyms are EMR and EHR. So these two terms are sometimes used interchangeably, but usually an electronic medical record refers to a partial digital health record that's under custodianship of a healthcare provider. And an electronic health record is a complete health record, also under custodianship of a healthcare provider. And then you can also have a personal health record, which can be a complete or a partial health record, but this is under custodianship of an individual like a patient or a family member. So later on this morning, Jill will actually be discussing Connect Care, which is our new provincial EHR initiative And I'm not going to give away any spoilers, so looking forward to Jill's talk later on. But today I will be focusing on data from primary care EMRs. So at the moment, most primary care practices will not be included in the Connect Care initiative. So it's still a relevant and important piece to talk about when we're discussing health data in Alberta. Okay, so why the focus on primary care? So it's a really important component of the healthcare system. So the vast majority of Canadians see their primary care provider annually, and it's estimated that close to 90% of older adults will visit their family physician at least once per year. Primary care is considered the gateway to the healthcare system. It's usually where the first point of contact occurs. And the predominant model right now in primary care is what's called the patient-centered medical home. And this refers to the provision of comprehensive primary health care with strong continuity, so good long-term relationships between patients and their care team, as well as coordinated and integrated care that incorporates patients' preferences and expectations. So within the primary care setting, there are many different conditions, symptoms, and activities that are looked after throughout all parts of the life course. So this is also the setting for prevention, disease treatment, diagnosis, and long-term management. And then lastly, countries with a well-defined and robust primary care system are generally associated with better and more equitable health among their populations, as well as more effective healthcare delivery. Okay, so hopefully I've convinced you how important primary care is. So let's talk about data from primary care and what we can do with it. So the best source of information about primary care is contained within electronic medical records that are used in this setting. This type of data is relatively new in Canada, especially as compared to administrative data. And I'll give you an example. So in 2006, approximately 20% of physicians in Canada were using an EMR system, and the rest were using paper charts. By 2017, so just over 10 years later, there was well over 80% of physicians who are now using an EMR. And among family physicians, this is closer to 85% or even more. So as you can imagine, until fairly recently, we really didn't have access to large amounts of EMR data. So given that this webinar is titled Big Data in Primary Care, what do we mean by big data? So there really isn't an explicit cutoff for what constitutes big or small data. But generally, there are three pieces of information that can help determine whether something would be considered big data. And these are referred to as the 3 V's: volume, variety, and velocity. So EMRs can certainly produce a high volume of data. So there's lots of information for many, many people. In terms of variety, primary care EMR data does have a large amount of variety. So there's both structured information and unstructured data. And then lastly, velocity describes the speed or frequency at which the data are generated, captured, and then made available. With primary care EMR data that we currently have access to for secondary purposes, it probably wouldn't be considered high velocity because it's not streaming or it's not real-time data at the moment. So the data within EMRs can be very useful for research, but they are also very complex. So we can get large volumes of data that can be extracted relatively easily. The data are routinely captured by physicians, nurse practitioners, and other healthcare professionals. And most EMR data from primary care will include lots of rich clinical details and information about risk factors. And most of this is longitudinal. primary care EMR data also consists of information from real-world populations. And this is unlike data that are gathered for clinical trials, for example. So that being said, there are a few important limitations that we will discuss. So generally, you only have access to a subset of all patients and providers. So these data are not considered population-based, but for research or surveillance purposes, you can obtain a sample of data that is more or less representative of the larger population of patients and providers. So as I had mentioned, the data are sometimes unstructured or entered as free text, and this can get quite messy. So for example, in our Southern Alberta database, we looked at the EMR data and found that there were about 60 different ways that diabetes was being entered into the medical record. And diabetes is not that uncommon, but you can see all sorts of examples of different text words that are used, misspellings, abbreviations, and all of this needs to be cleaned up and standardized before you can really use the data for other purposes. So this brings me to my last point. The EMR data itself and the analysis of EMR data is actually pretty complex. There's a lot of work that needs to be done to clean and prepare the data. And then when you use these data for research, there are lots of different methodological and analytic decisions to be made, and some issues that you need to contend with. And hopefully Paul can describe some of these examples during his talk. Okay. The largest source of primary care EMR data in Canada comes from the Canadian Primary Care Sentinel Surveillance Network. That's a bit of a mouthful, so we usually just say CIPSEN. CIPSEN started in 2008 with funding from the Public Health Agency of Canada. And the purpose was to develop what's currently the first and only source of pan-Canadian primary care EMR data that's made available for disease surveillance and health research. So CIPSEN functions as a collaboration of 11 different primary care practice-based research networks in 7 provinces. And you can see them here represented as the little dots on the map. Each regional network is responsible for recruiting CIPSEN sentinels, and these are mostly family physicians, but also nurse practitioners and some community pediatricians. And they contribute de-identified patient data from their EMRs. We extract data twice a year, and then the data are cleaned, processed, and standardized regionally before the data are merged in our central repository at Queen's University. Okay, so these are some of the data that make up the CIPSEN database. All the data within the database are de-identified. So the national CIPSEN data contains some select provider and clinic characteristics, such as birth year and sex of the provider, whether the practice is in a rural or urban setting, and whether it's an academic or non-academic practice. So in terms of patient information, there are a few non-identifiable demographics. We have information about the encounter or visit to the primary care practice. So whether it's a diagnosis, a symptom, sometimes there's queried diagnoses. So we also have physician billings, lab results, prescribed medication. So these are medications that have been prescribed, but we can't confirm if they've been filled at a pharmacy. We have physical measurements. These are things like blood pressure values, heights, weights, BMI, medical procedures. There are allergies, anything about vaccinations, risk factors. Generally, this refers to smoking status, there's also information on alcohol use, diet, and exercise. We have some information about referrals to other specialists or organizations. And then we have SIPSN case definitions. And these are something that we've created. Obviously, there's a lot of information here. And so sometimes it's difficult to know for certain if a patient has a condition or not. So we've crafted these case definitions that looks at various parts of the medical record, looks at different text words, different diagnostic codes, medications, to try to figure out, to the best of our ability, whether a patient has a certain condition or not. And then we validate it and see how accurate those definitions are. Okay. So in the most recent national SIPSN database available, which is data up to December 31st, 2019, there are just over 1.8 million patients, and this is roughly just under 5% of the entire Canadian population. So there are almost 1,600 providers contributing data from 257 practice sites, and we're pulling data from about 12 different EMR systems. In terms of volume, this database has over 52 million encounters or visits, just over 41 million records of prescribed medication, and there are over 28 million physical measurements, things like heights and weights. So as you can see here, it's an extremely large database. Okay, so in Alberta, we have 2 regional practice-based research networks that host SIPSN. One is the Northern Alberta Primary Care Research Network, or NAPCRIN. This is located in the Department of Family Medicine at the University of Alberta. And then we also have the Southern Alberta Primary Care Research Network, or SAPCRIN. And SAPCRIN is in the Department of Family Medicine at the University of Calgary. And since I'm affiliated with SAPCRIN, I'll just be providing a little bit more information about what we do here. Okay, SAPCRIN was started in 2007 by Neil Drummond, who is the current director, and it's now grown to include more than 300 members. SAPCRIN is a collaboration of members who include family physicians, nurse practitioners, other healthcare professionals who are interested in primary care research, along with academic researchers. And the goal of SAPCRIN really is to answer research questions that come from clinical practice and that are seen as important, relevant, and timely for primary care. So if you think of SIPSN as the data engine, you can think of SAPCRIN as, I guess, the vehicle that drives primary care research. And we have a website, sapcrin.ca, so that will give you a bit more information about who we are and what we do. Okay, well, what do we do? Because primary care covers such a wide range of conditions and activities, the health research we do is also quite broad. And so one example is the work that Paul is leading. He'll be describing that a bit later on. It relates to chronic kidney disease. So another example, we were able to use the blood pressure measurements in the National SIPSN database to estimate what the prevalence of high blood pressure would look like in Canada if we were to adopt the new guidelines that were recently issued in the US. And these guidelines lowered the blood pressure threshold that is needed to diagnose someone with hypertension or high blood pressure. So we're also participating in a pan-Canadian trial to help address polypharmacy, and this is the use of concurrent and multiple medications, specific to older adults. This study also uses data from CIPSIN to generate the reports that are given to providers around polypharmacy in their practice and prescribing patterns. So this is an example of disease surveillance that we've done. This one focused on describing the rates of dementia in primary care and how dementia is being treated. So we also undertake initiatives that are related to practice improvement or quality improvement. We've created a few condition-specific online dashboards for clinics and for individual providers. And you'll get to see this in action after my presentation. So Matt Taylor will be demonstrating one of these dashboards. Please stick around, it's very cool. Each participating CIPSIN Sentinel is also provided with a report after each of the data extractions. And this is based on their patient panel and provides comparisons to other providers within the clinic and providers across Alberta. So when data comes out of an EMR, it's usually very messy. So there is a lot of work that we need to do to make it usable for research and surveillance. In Alberta, we do focus very heavily on EMR data quality and improvement. And some examples are, Matt's again put together some very cool data quality visualizations so we can see very quickly how complete some of our data elements are. Again, I had mentioned the case finding or the case definition work that we've done. These algorithms, we've started to generate them using machine learning methods. We're also using some machine learning methods for cleaning up the data. The one we're working on right now is related to the prescription medications. Okay, data linkage. This is not something we're doing fairly regularly in Alberta, but we have been working hard at creating a more efficient process to be able to match our CIPSIN data to administrative data. So this is really exciting work because we'll be able to understand a lot more about patient care throughout the entire healthcare system. And so one example of research that will be possible with data linkage is we could look at medications that have been prescribed by a primary care provider. This would be in the CIPSIN database. And then what proportion of these medications are actually filled or dispensed at a pharmacy. And then those data would come from an administrative database related to pharmacy records. I apologize for all the acronyms here. We do work a lot with many different groups and organizations, and this is really to help make the work accessible and relevant. So CIPSIN itself is a collaboration of many different practice-based research networks, and we often work together on various research projects. So the SPORE pick-ins, so it's the primary and integrated healthcare innovation network. So this is really the link to all the other SPORE programs for anyone who's conducting primary care research, such as the support units. We're also involved with the strategies for patient-oriented research, chronic disease networks. For one, we are a provider of CIPSIN data, and for others, we collaborate on research projects. So there's a new Center for Health Informatics at the University of Calgary. This is really a hub for EMR analytics. So we contribute knowledge to this group, and we also learn a ton from other folks in the Center for Health Informatics. We're also involved with the Primary Healthcare Integration Network in Alberta. So it's a unique strategic clinical network, or SCN, with both a scientific arm and a clinical practice arm embedded within our provincial healthcare system. So these are just a few examples. And then lastly, just a bit of information about how you can access the data or information about how to get involved. So for those researchers who are interested in obtaining the national SIPSN data, this is the site where you can go to put in an online data request. You need to have research ethics approval, and then you submit your electronic letter of intent through the website. You can request regional SIPSN data. So for SAPCRIN, this is the website where you can go to get more information and to submit a request. You can also join SAPCRIN. So if you're a family physician, a nurse practitioner, someone who's just interested in primary care research, you can fill out a little form on our website, and we are always welcoming new members. Some of the things that we do for SAPCRIN is distribute a newsletter twice a year, and we also used to have an annual members dinner, although this spring we unfortunately had to cancel due to COVID, but hopefully we can reorganize something next year. For those who are interested in joining SIPSN, you can just send me an email. I can provide a little bit more information. And then we also work closely with the PIHCI Families panel. So they do review a lot of our research proposals just to make sure that it is relevant from a patient perspective as well. So here's the link to find out more information about the Families panel. And I believe Cliff Lindeman is the contact. His email is on that website as well. And that's it for me. So thank you.
Thanks, Stephanie. Okay, our next panelist will be Paul Ronxley. Paul, would you like to introduce yourself? And I believe you're going to be sharing your screen for some slides. And Steph, you can take a break and turn your video off for a little bit. Perfect. Go ahead, Paul, whenever you're ready.
Okay, so thanks so much for the opportunity today. I'm Paul Ronxley. I'm a health services researcher at the University of Calgary. And today I'm going to follow up with what Stephanie's been talking about, looking at the Canadian Primary Care Sentinel Surveillance Network, which we're going to call SIPSN, and talk specifically about a specific chronic condition, so chronic kidney disease, and the surveillance program that we have going for that specific condition.
Just need to start your slideshow, Paul.
Oh, sorry, it's not started yet. Okay, it's
no.
sharing screen, but it's not showing here. Let's see if I can try that again. Can you see the slides here?
We can see the slides, but it's still in the format of like where you have all the ones on the side.
Sure, let's see if this is going to work here.
Perfect, great.
Is that better?
Yeah,
okay,
go ahead.
Okay, sorry about that. Okay, so I have no disclosures or conflicts of interest for this talk. For the next 15 minutes or so, I'm going to tell you about, first off, what is chronic kidney disease and why it's important to identify and manage in primary care. And then the plan is to show you how SIPSN data can really answer some important questions about how patients receive care in primary care. And I'm going to talk specifically about the SIPSN CKD program of research that we've developed and show you some of the really high-level results from that, but also some of the work that we're going to be doing. So first off, what is chronic kidney disease? So let me call it CKD. And so this is a chronic condition that's really characterized by a gradual loss in kidney function. So you can kind of think of it on this figure here on the side here. So when our kidneys are working at 90 to 100%, they're effectively filtering our blood and removing waste. But as the kidney function starts to decline and the percentage starts to go down, their job isn't as good anymore. Eventually, once you get to about 15%, that's considered end-stage kidney disease. And so the kidneys are no longer functioning very well, and you may require a kidney transplant or something called dialysis to clean your blood. And so essentially there's 5 different stages of chronic kidney disease. And there's some key facts about CKD. So I've mentioned there's 5 diseases. Stage 5 is the most critical, where you'd require a transplant or dialysis to kind of maintain kidney function. It's estimated that about 1 in 10 people have some form of kidney disease. So that's usually stage 3, 4, or 5. It's estimated that about 10% of people have that in the population. Men are more likely to develop or progress to kidney disease. And there's a number of well-defined risk factors for chronic kidney disease: diabetes, high blood pressure, heart disease. There's lifestyle factors such as smoking, obesity, age, family history as well. One of the nice things is that it's very easy to identify people with CKD through a simple blood test, where you can measure something called serum creatinine. And from a serum creatinine, you can measure an estimated glomerular filtration rate, an eGFR. And that's used to define how well your kidneys are working. And you can also use a urine test to identify if there's something called protein in your urine, which is also a bad thing. And so why is CKD important, or chronic kidney disease important? Well, first off, chronic kidney disease, specifically at later stages, is a major burden on patients in the healthcare system. And as I'd mentioned, it leads to kidney failure, which may require dialysis or transplant. But there's also an increased risk of heart disease and stroke amongst patients that have chronic kidney disease. There is evidence that if we identify people early and provide them with effective management, so that might be lifestyle modification or pharmacotherapy, there is the possibility to slow the progression of CKD and reduce that risk related to cardiovascular complications. The unfortunate thing is that it's very hard to identify CKD because it's really a silent chronic condition. So most of the time you don't know if you have it until a very late stage, at which point the interventions that I've talked about are not really as effective. So the fact is, most people are diagnosed with CKD in the community by a primary care physician. And so this has led to a big surge in the interest of improving primary care programs for CKD care. And this is where the CIPSIN database really comes into play. And as Stephanie had mentioned, CIPSIN already has a multi-disease surveillance initiative that's been developed. And this platform is ideal for a national surveillance system for chronic kidney disease, in that CIPSIN already has blood test values from most of the Canadian population. So we can use this to actually identify people that have chronic kidney disease. And I should mention that there are only a few countries in the world that actually have a CKD surveillance program. So there's the US, there's England, and Japan. They have a national system in place. Australia has a system in place for one of their states, which is Queensland. And then we've got our system here, which is CIPSIN CKD. And this is a passive surveillance system that we developed in 2017. And I'll talk a little bit more about that and the work that we've done with this surveillance system. So first off, we developed a multidisciplinary and cross-jurisdictional team that included health services researchers, nephrologists or kidney doctors, and family doctors from a number of different universities across Canada. We also had international collaborators from the US and from the UK. And the first thing we did was apply for some funding. And fortunately, we got funding from the PIHCCI network in collaboration with PIHCI through one of the Quick Strike programs to do some of this work. And this was led by Dr. Aminu Bello at the University of Alberta. And he's been driving some of this work forward. Unfortunately, he wasn't available today, so I'm presenting some of this work on his behalf. And the first thing that we did was we developed a protocol to say, how are we going to do some of this work with the funding we received, and what do we want to do in this national surveillance initiative? And so we developed 3 main objectives in how we'd use CIPSIN for this work. The first, we want to determine the prevalence of CKD in primary care settings in Canada. We also want to look at current practice patterns in terms of risk identification and management, and then also see if people with CKD are being managed based on established quality indicators and how that care varies across different provinces in Canada. And so I'm going to show you some really high-level results of the work that we've done here. So that first paper that we did was really looking at the epidemiology of CKD in a primary care setting. So looking at prevalence, demographics, and how it varied by different factors. And what we found was that within the SIPSN database, we identified almost 600,000 people that had 2 or more eGFR measurements. So eGFR, as I'd mentioned before, is the estimated glomerular filtration rate, and that's how you measure kidney function. And so if someone has an eGFR of less than 60, that's considered CKD, to have CKD. So we identified almost 600,000 people within this 5-year period. We identified 41,000 people that had CKD as defined by an eGFR of less than 60. So that works out to about 7.4% of the Canadian population, which is very much in line with what I had mentioned before, around 1 in 10 people have disease, and very similar to what other surveillance networks have seen in primary care. We also saw that CKD prevalence changed by level of material and social deprivation. So we see in this graph here on the left side, patients that were most deprived actually had a higher prevalence of chronic kidney disease, and that's the purple line, and that remained the highest across the 5 years of data that we had. We also saw that CKD prevalence was higher in rural settings compared to urban settings, and that's the figure on the right side here. And as expected, we also saw a higher prevalence of CKD among people with multiple chronic conditions or multimorbidity. Once we finished the quality of care indicator, the prevalence study, we also published in that same year the quality of care indicators paper. And this was looking at are people with chronic kidney disease, those 40,000 people that we identified, are they receiving guideline concordant care? And to do that, we actually identified 12 different CKD quality indicators in primary care. And these are in the red boxes here. So these are detection and recognition of CKD, testing and monitoring of kidney function, use of recommended medications, monitoring after initiation of ACEs and ARBs. So ACEs and ARBs are 2 types of medication that are shown to slow the progression of kidney disease, and then management of blood pressure and monitoring of glycemic control. So we know that a lot of people with chronic kidney disease also have high blood pressure and diabetes. So managing those 2 chronic conditions is paramount to slowing progression of CKD. So of these 6 domains, there was 12 different quality indicators. And what we found was that overall, 4 out of 12 of those quality indicators were being well met in over 70% of patients. And in fact, 6 out of the 12 were being met by 50% of patients, which is actually quite good. And so here they are here. And the ones that I'll maybe highlight for you is under kidney monitoring. It looks like family doctors and primary care physicians are doing a very good job at using serum creatinine testing in the 18-month period following a confirmation of CKD to monitor kidney function over time. So you can see 85% of patients are receiving that specific test. Primary care physicians are also doing a great job for blood pressure monitoring and glycemic control. However, from this figure, you can also see that UACR testing here at 27% is quite low. So UACR is the urine albumin creatinine ratio. So that's a urine test to identify if there is protein in the urine. And this is another way of identifying and monitoring kidney function. So the takeaways from this is that most of the quality indicators in primary care were well met, but it looks like albuminuria, so looking at identifying protein in the urine, detecting that and managing that, is suboptimal in primary care. So we've identified a potential gap in care and something that we can work on specifically with primary care physicians. And the reason that's important is we know that protein in the urine is linked with cardiovascular and renal risk as well. So those are two specific papers that we've been working on, but we have lots of other projects that we want to do. The first one that we're currently working on right now is looking at quality indicators among people at high risk for CKD. So not amongst patients that already have chronic kidney disease, but those that are at risk. So people with diabetes, hypertension, and cardiovascular disease. Are they receiving appropriate guideline concordant care to reduce the risk of getting or developing CKD in the future? As Stephanie mentioned, polypharmacy is also an area that we can look at within SIPSN. So how common is polypharmacy in CKD patients? What proportion are receiving potentially inappropriate medications? And is that associated with a potential decline in kidney function over time? And as Stephanie had also mentioned, it's possible that we can link SIPSN data with administrative data sources in Alberta and look at potential associations between chronic kidney disease management and different health outcomes, whether it be acute care use, so hospitalizations or emergency department visits. We can look at adverse events, so maybe heart attacks or strokes, and even progression to dialysis. So if we see that CKD management is effective, do we see that it actually has a slower progression to dialysis or the need for dialysis? So just to kind of wrap up here, I hope I've convinced you that SIPSN is an ideal platform for chronic disease surveillance, and that the fact is that we have routinely collected data on a number of people across Canada, and we can use that to better understand patterns and variation in care for chronic disease. And I've shown you what that looks like for chronic kidney disease, but this is essentially can be done for a lot of chronic conditions within this platform. And this is really the first attempt to develop a surveillance system within Canada that we can look at prevalence and patterns of CKD care. And the ultimate goal of this work is to develop strategies to refine how we deliver care for people with chronic kidney disease, ideally reduce the burden of that chronic condition, and improve patient outcomes. And so I'll leave it at that. I'm happy to answer questions after the sessions are done, but I'll leave you with a couple of pictures of some famous kidneys that you may not be aware of. So thanks for your time today, and I look forward to questions you have.
Thanks, Paul. That is definitely academic humor. That's okay. I'm well versed in geek speak. It's one of probably my second language. So I'm gonna ask now that Matt is going to share some, I guess, more hands-on stuff about what you can get out of SIPSN. So Matt, do you want to share your screen and go ahead?
Unmute. There we go. Hi, my name is Matt Taylor. I'm a data manager at University of Alberta. And one of my jobs is as the software developer for a product, the SIPSN data presentation tool, or the DPT. And sort of that's the basis for our CKD report, which I'll show you in a moment. So the purpose of the data presentation tool was in SIPSN we have a lot of different a lot of physicians submitting data, but it tended to be where they would submit and would never really see where it went or see what we did with it, essentially, right? So so by creating this web application, we're able to sort of feed that data back to physicians, let them take advantage of the things like SIPSN's algorithms for coding and cleaning. For instance, if you wanted to find, say, a patient taking medication or something like that, our algorithms are very helpful in sort of smoothing over misspellings and generics and things like that. And there's a lot of other ways that the SIPSN coding helps. So I'll sign in really quick. And there we go. I'll jump very quickly to the report here. So this is the chronic kidney disease dashboard. And so this was created with the intention, so much as Paul said, with as far as sort of monitoring a patient population that has chronic kidney disease or is at risk, or so in this set of demo data, we've loaded it up. And one of the real advantages of having this as a web application is we can do a lot of neat things with how we report it and interactivity and aspects like that. So Let's see, I'll demonstrate the tools that we have here. Let's say, change those settings. So here you can see we have 1,081 patients loaded up across 3 providers. And so the denominator here would be patients who have an EGFR lab value. We can see that a fraction of them have below 60, which is the CKD definition. And so with each of these graphs, they're all sort of interlinked and tied together so that you can really ask a lot of questions about it and find those answers really easily. So if, for instance, we wanted to only look at the set of patients in this denominator who are over 65, we can just click and drag and sort of set a window, and we can see how everything changes based on the filters we set. So it helps to see relationships between data, and those are associations. It helps to learn about the data, and of course, with the management piece of it too, the understanding those patients, being able to find patients who potentially need an intervention, for instance. So we have, like, if you wanted to find patients that have an EGFR below 60 and haven't had that ACR, so that was one of the interventions mentioned earlier. You can just run a search for those, and it just creates a list of the patients that can be re-ID'd later. But so in terms of the variables that we have, so we have age, sex, and distance from clinic. We have the two primary labs for doing it. We have exam values. So these are the measurements, like BMI, height, weight, blood pressures. We have deprivation scores that are calculated based on the patient's postal code. And so we can see, we can compare, we can set a range and see how everything changes based on setting any of the individual parameters, like filtering on them. We do have a list of patients. So if you were looking, for instance, for your patients who, let's say, who they're not on an ACE or ARB, and over 65 again, so we can narrow it down so that you see that 132 of the 1,081 match those criteria. And so we actually get a list. So this really helps if you want to create a list of patients for, say, doing a callback or something like that, and who need those those interventions. You're able to find them really easily. And yeah, so all the medications, comorbidities, you can either select whether or not they have, you either include them or specifically exclude them from the set that you have. And we have the sort of numerical statistics too, if you want to sort of compare between different sets. And last but not least, we also have a calculator that's sort of generated for each one of the patients too, that you can bring it up, and if you want to just by let's see, you're able to it sort of interactively calculates what their not just their stage, but also the 2-year risk and 5-year risk of kidney failure, and see how changing one value makes a difference, and sort of explore that. Yeah, and so I think that's about it for the kidney report.
Okay, thanks. That's was very helpful to see this concrete. Is there anything else you'd like to share before I move on to Jill?
No.
Excellent, great. So now we're going to turn it over. Thank you, Matt. We're going to turn it over to Jill. I'm just going to start my video for a second. Jill, if you want to go ahead, and you're going to let me know. Would you like me to share my screen right away with your graphics? Nope, you're going to let me know. Okay, I'm turning off my video, and I'm waiting to hear from you, and I look forward to hear what you have to say about this.
Good morning. As Jillian has stated, my name is Jill Bernhardt. I live in a very small community in the extreme southeast of the province of Alberta, where it's going to be 37 degrees today. I have been a member of the Alberta PIHCCI team for 4 years as a patient advisor. Today, I will focus on my experiences as a patient advisor in the development of an initiative called Connect Care. I will attempt to describe why it's absolutely necessary to include the perspectives of patients and community members in the design, development, and rollout of initiatives that impact the care people receive to ensure that unintended consequences of big data systems are avoided. So to begin with, a little background. Alberta covers an area of 662,000 square kilometers. It has a population of over 4 million people. 2/3 of that population live in the metropolitan areas of Calgary or Edmonton, and the remaining 1 million in the smaller towns, cities, and rural areas. Before 2009, healthcare in Alberta was delivered by 12 health authorities. To make the delivery of care more efficient, in 2009, they were amalgamated into one health authority called Alberta Health Services, which I may refer to as AHS, consisting of 5 regional zones, Calgary, Edmonton, and 3 rural areas. During the AHS formation, patient information was collected and stored by using more than 1,300 different systems. This included everything from pen and paper to a variety of software platforms, which were sometimes not compatible with each other. The range of systems made it difficult, if not impossible, for health professionals to access information should a patient move or need care away from the local hospital or clinic. A better solution was definitely needed. To address this problem, in October 2017, after almost a year of consultations with hundreds of physicians, staff, and patients, a contract was signed with Epic Electronic Medical Record Systems. Epic would act as the prime technology partner for AHS to base a new system called Connect Care, which aims to give healthcare providers a central access point to patient information, common clinical standards, and best healthcare practices. I was fortunate to be a member of the Provincial Patient and Family Advisory Group, providing advice in the development and implementation of Connect Care. The Patient and Family Advisory Group has about 30 community volunteers, representing a variety of ages, backgrounds, culture, geographic areas, gender, and education that reflect the population of Alberta. The mission of this group is to work with AHS in an advisory role to enhance patient-centered care in our province. In late 2017, Alberta Health Services requested that some of the members of the Patient Family Advisory Group attend the Connect Care developmental sessions as patient advisors. For people like me who live in a rural area, it would mean a great deal of travel time. My commitment was for 24 days volunteering away from home. And so my journey with Epic and Connect Care began. The first direction setting session was held in Edmonton in February 2018 on a very, very cold day. 2,400 people attended these sessions, and at one time we were all in the same room. Executive members of AHS spoke about empowering the patient and patient-first commitment. Epic spoke of Connect Care's 4 pillars: patient first, people strength and commitment, technology, and research. For most of us, it was totally overwhelming. There were breakout sessions that covered 20 different topics, but were brought to a level that could be better understood by the average non-medical community member. Input was gathered from staff, physicians, and patient advisors to guide what would be included in the potential clinical information system called CIS. This system focuses on how common tasks used in providing patient care are complemented by information flows and tools. All aspects of patient health were represented to help navigate on how their workflow and processes would be designed into the clinical information system. The 50 patient and family advisors were a very vocal group. We constantly reminded those in attendance that we were talking about real patients and their families, the people behind the numbers and the acronyms. Our voices were taken seriously, and we were provided with the same voting privileges as the professional staff, and soon learned that if you raised your red card in opposition to an idea or concept, you should be ready to defend your position. One of the most powerful sessions was my chart, which is now the Connect Care patient portal. This portal is the integrated health record of each patient and facilitates seamless health care that presents health information to patients. Information like medication, history, previous health concerns, and doctor's notes will be included in this portal. Patients are also able to add their own notes and questions. Albertans now have access to their own My Chart, thus empowering people to be equal partners in their own health journey. So Jillian, if you could show the patient slide. Okay, this slide is a snapshot of the access to the patient portal, showing what can be accessed. So you can see there all the different things that the patient can access and see their own results. Okay, the second slide informs the patient that there are results that are showing on their patient portal, and that all they need to do is use a secure login and password and review the results and see if the doctor has requested any follow-up visits. Thank you to Jennifer Reese for allowing me to use her patient portal slides. Okay. Extensive training has been and will be given to physicians and frontline staff before Connect Care is launched in their areas. There is a provider portal to connect community members to the clinical information system, thus allowing requests for consults, scheduling appointments, placing orders, or exchanging secure messages with the patient's circle of care. Connect Care was scheduled to go live through a series of process waves between late 2019 and late 2022. Training was scheduled to begin at least 2 months before Connect Care was set to launch at each site. Online training and information became available in early 2019. Following the successful first launch of Connect Care in Edmonton in late 2019, the COVID pandemic arrived and work had to be put on hold. Where Connect Care had been implemented, it was of great assistance in the expansion of virtual care to patients. Ultimately, when Connect Care is fully rolled out, it will mean that all of the Alberta Health Services and patients will have access to the best possible information throughout the patient's health journey. So, why would a senior grandmother from a small town in Alberta want to become involved in such a huge project like Connect Care? I'd like to share something from my own family's experience that drew me to commit my time as a patient and family advisor to this project. In 2012, our 34-year-old daughter underwent several medical tests and medical imaging and sought medical attentions 3 times during the first week of November. Her faxed test and imaging results were never received. No documentation tying her results or her clinic visits was made. She died very suddenly on November 9th of 2012. I believe unequivocally that had she been able to view her own health record and results through a patient portal like Connect Care, the outcome might have been different for my family. I have made it my mission to help improve the health communication between patients, clinics, and physicians. It has been a soul-searching experience with the reward that Connect Care may lead to life-saving communication. This, of course, has just been a small overview of the Connect Care system from the perspective of a patient advisor. If you have any questions, please don't make them too technical, as that's not my area of expertise. Thanks.
Thanks, Jill. And I'm going to ask all our panelists to turn their video back on. That was a very interesting overview and inspiring story. And for small world connections, I actually, when I was younger, lived in a town not that far from where Jill is now finding herself. Would embroiled be the right word with did you say 39 degrees, 37 degrees?
37 degrees.
That's horrible.
It's hot. It's hot. We have air conditioning.
Yeah. You also have cactuses and rattlesnakes down there
we
too.
We do have all of that, and scorpions too.
Yes, yes, I do. I remember. Yeah, all coming back to light bulb. Okay, so we're going to move on to our question and answer session. So thank you to all the panelists for participating. And so we've got a couple of technical questions first. So Jill, you may be off the hook on those. You did quite clearly say you're not going to take technical questions. So one of our questions here is from Tayab Shah, who is asking, what is the smallest geographic information available for SIPSN data? So whether you have street, postal code, street address, how do you keep track of people? I think maybe for people that don't understand SIPSN, you can talk about this from what the data you get in versus what you're allowed to share, because they're not the same thing, right? So
Sure.
I'll let my panelists answer that.
Okay, sure, I can take this one. Within the clinic setting, a lot of information can be input into the EMR, such as the full name, address, telephone number of the patient. However, SIPSN is only extracting de-identified data, so we do not pull out street address, names, phone numbers, provincial healthcare numbers, anything like that. We do extract, most regions extract full postal code, and from that you can map that to a deprivation index. However, if you are accessing the SIPSN data as a researcher, you will only get the first 3 digits of the postal code or the forward sortation area. So that's sort of the smallest geographic piece of information that you would have access to. And you can ascertain whether that's a rural or urban location using the second digit of the forward sortation area.
Okay, great. Any other comments to add to that? Because the next question kind of follows up on that. In terms of the dashboard, again, Tayab commented, it's great work. He's just wondering if you're planning to include a spatial component as well. I know some work has been done on, for those in our audience that don't know about geographic spatial analysis, it looks at things like what is the density of healthcare access. So, you know, the small circles and medium and big circles that try and balance demand versus what's actually available in access. And they do this for food supplies and for healthcare. So is there any, it can visually be very arresting to see these maps with like where your demand's coming from. And I know Paul mentioned social deprivation, and that's often mapped out along with access to care. So I don't know if the dashboard lends itself to that, but is there any talk about including that?
Sure.
Matt, go ahead.
So the spatial component of the dashboard that's visible now is we do calculate the sort of the distance from the clinic based on the postal codes of the patient and we also know the postal codes for the clinic itself, so we're able to calculate that distance. Another feature we have in the DPT, although it's not in it isn't linked to the report, the CKD report, is we do have the ability to plot sort of overlay a map with a heat map style view that shows sort of where either your patients are or where people with a certain condition are, or really within where people within sort of arbitrary search terms are. So we do have that aspect of it. It's it looks really neat. I don't know how practical it is in a lot of cases, but it is interesting in to sort of play around with, and yeah.
Okay, thanks. I think there are other people in other areas that are interested in incorporating that. Paul or Stephanie, you have anything to add there about the geospatial analysis, you know, that non-technical topic? Okay, but people are looking more and more at these maps to make policy recommendations. So it's more like what happens, what comes out of this. And so if you're to open a new clinic, where would you open it? Or if you were to make more services available, where would that happen? So that can be extremely useful information for
I
that.
think in many cases too, you might want more administrative data for decisions like that, because CIPSN has it's a fairly large fraction, but it is still a fraction of the total patients. And because there are slight differences in how in representation, like in a certain community might not have any SIPs and docs, in which case it's difficult, right? So like the being able to sort of find everybody is difficult if you don't have everybody. Whereas administrative data, there's not as much of it, and it tends to be more specific, but it should be more encompassing.
Yeah, I think that there's, of course, my thing that I've always said is combining would be the best, because there's a lot of clinical data like labs and different things like that that are extremely useful that is not in administrative data for sure. Okay, so and now I've got a question for all of you. You might just have to speculate about this, but why did this get moved ahead in Alberta when EMR and EMR data is less available elsewhere? So I know SIPSN spans the country, but for sure it doesn't have implementation everywhere, and the type of information shown on the dashboard and the type of app that Jill talked about, I don't think that app exists elsewhere. So why do you think this got moved ahead in Alberta? And when we're really stalling in a lot of areas of the country. So what do you think pushed that ahead?
So it is
feel
actually,
free to
it is in several
widely
provinces.
speculate.
So
The Connect is as well?
Oh, sorry, not the Connect. I'm sorry. I think the dashboard.
Okay. Yeah, the dashboard. Okay, go ahead, Matt.
Oh no. Yeah, sorry. So the dashboard we do have in several provinces, but yeah, certainly there are different cultures and just different, among the medical communities. And I mean, we have in SIPSN we have networks in a lot of provinces, but some we just, for whatever reason, there's sort of never been. It hasn't been created. I know there isn't one in Saskatchewan currently. Yeah, well, that's just.
I think that's exactly it, Matt. I think that we're fortunate in Alberta to have the infrastructure in place to start and develop these EMRs and hopefully work out some of the kinks so that when other provinces are available to be on board, we've learned from the mistakes that Alberta has made and in other provinces. But I think that it doesn't make sense to just wait until everyone's available. I think that we have to continue to move forward and to provide data to care providers when it is available, and just continue to to push the envelope and make it better.
Yeah, so I guess there's sort of two different things happening. One is SIPSN and the primary care EMR data, and the other is Connect Care. If I were to speculate, I would say, one of the advantages in Alberta is that we have a singular health service delivery. So Alberta Health Services encompasses the entire province. So potentially that made it more feasible to implement Connect Care in that provincial EHR. And I think potentially at the time, perhaps maybe we had the budget to roll out or to take up the Epic EMR software and implement Connect Care.
Okay, thanks. I'm going to jump down in the questions and ask a related question. One of the people said great work with SIPSN, but has there been any connection with Saskatchewan to include their data? There seems to be no data from Saskatchewan so far. So any comments on that? You may not know, but
yeah, again, if I think the main reason is just so SIPSN is essentially a project that's run through primary care practice-based research networks across the country. And to my knowledge, I don't believe there is a practice-based research network in Saskatchewan that has the infrastructure and the funding that can take on the SIPSN project, do the recruitment. There are some vendor fees. So there's quite a lot of work resources and infrastructure that's needed. So that would be, I think, what's happening in terms of Saskatchewan. Of course, if it were the case that they did have infrastructure and were able to join CIPSIN, I mean, that would be amazing. You wouldn't say no to that.
So I know that, just to let our audience members know, by the way, SPORE stands for Strategy for Patient-Oriented Research. It's a big funding initiative through the Canadian Institutes of Health Research. And they've recently funded something called the National Data Platform that's meant to combine more easily data sources across Canada. And when it was funded, CIPSIN was not part of that, but we are looking to see how that can be included, because they are still missing that insider's view of primary care data. And for anybody who's been attending these series regularly, you will now realize that primary care is 80 to 85% of care in Canada. So that's a big piece of the picture to be missing when we're doing research and when we're looking at data and making plans. So I do hope as well that we can get this regulated and consistent across the country, because I know it exists in Quebec, but it exists in Quebec in only one of our practice-based research networks and not all of them. And we have 4 university-based networks. Okay, thank you. All right, so I'm gonna go back up into the top of my questions. So this is an interesting question because it relates to primary care. Primary care is not just family physicians. Family physicians do provide a big chunk of the care there, but they are not the only healthcare providers. So Dale Halas is asked, as a primary and integrated healthcare innovation network, that's what PIHCI stands for, terrible acronym, is there development that will enable us to obtain data about the interactions with other healthcare providers beyond the family doc, nurse practitioner, pediatrician? So these could be social workers, it could be clinical psychologists. So thoughts on how to, because I think one of the things that Jill was mentioning is the importance of connecting. It's called Connect. So how do you track these interactions with different members of the system, given that we are definitely going towards interdisciplinarity? And I think you mentioned that in your presentation, Paul. So thoughts on that? The easy question.
Sure. So one thing I can tell you is that we do have a few nurse practitioners. I'm not sure if, I know there's been discussion about pediatrician. I'm not sure if that's whether they're currently in the data set, but I know that that has been something that we've talked about. I guess one of the concerns, so basically, if I think in a lot of practices where there are nurse practitioners, they still, because it's integrated, they still have that sort of that EMR based, for doing the scheduling and for billing probably, and the other services they provide. So from our perspective, as far as pulling data out, it doesn't. As long as they're working in an EMR, their actual sort of role there isn't it's sort of attached to the patient anyway, so we're able to pull that data, and we see the patient as a single person, and so we'll see the encounters they might have with a physician at a clinic, and also a nurse practitioner, and same with the pediatrician is that they would probably use an EMR much like any other physician's office would. So the specific examples there are sort of included, but certainly there are other cases. I know with referrals to, there isn't really that, we're not really able to sort of track through to see that they went and sort of tied those two together. So we know they've been referred, but we don't know if they made the appointment. And there are some other services too, like certainly I know some imaging services don't necessarily go through the physician. Things like eye exams, for instance, can be done and it doesn't really come back to your physician when they're done. And certainly that's something we'd really like to know for diabetes. So there are a few places where there could certainly be improved, but those specific examples we can sort of cover now.
Other thoughts from Jill? What was your experience in terms of the Connect capturing different, because of course that's one of the issues, right, is fragmentation of information. Did you find that Connect helped with that? Were you able to put in or get all the information you want, or are you still shopping around for some information?
No, I think I think that Connect Care, you know, as I said, it's only been launched in the Edmonton area. I think as it continues to be launched throughout the province, which down here where I live may be 2023, you know, I think that all of the information is going to be available.
Yeah, that would be fantastic. So any other comments about that capturing, including records like that's the interesting one, the eye exam. I mean, I didn't even think of that, and I'm in this field. But also, I know, I guess, well, one of the ones, I'm a classically trained pharmacoepidemiologist, so one of the ones that always gets me is the over-the-counter medications. Like that way, who knows?
From what I understand, that in the patient portal, all of that's like over-the-counter medications, prescribed medications, treatments will all be included in the patient portal.
Okay, great. All right, so that's quite encouraging, but because I know that just providing our clinicians with information on other prescribers was already a big eye opener. So it should be interesting when they get a bigger picture of how people are taking care of their health. Okay, thank you for that. So our next question, all right, this is, these are some great technologies. How can data throughout the country be combined for a larger data set to be analyzed? So I know I was involved in SIPSN when it began. I was a consultant for them, and I know the privacy hoops they had to jump through. And this data is available. I do know the data is available because one of my PhD students used it and analyzed it for her PhD. Does anybody want to talk about how the data, where the data gets sent and how it gets treated?
Yeah, so I can maybe talk a bit about the SIPSN data. So each regional practice-based research network will do the data extraction, some cleaning and standardization, and then a copy of that data is sent to our national repository at Queen's University. So all the data, all the SIPSN data from regional areas across Canada does get merged to create a big national database. It gets a little tricky when you start linking data. So when you link the SIPSN EMR data to administrative data, because of health legislation that varies from province to province, at the moment you are not able to combine that linked data all together into one massive EMR and administrative linked database. So some groups do sort of like distributed analyses. So they create the analytic plan and code, and then that's just replicated within each province on, you know, administrative or linked data. Yeah.
I'll just add one extra part to that, and I think the one of the keys for data linkage is having unique identifiers available within the different data sets that you want to put together. And so that may include a provincial healthcare number or age or sex or postal code, and items that you can use to potentially do a deterministic link or a probabilistic link. I think that sometimes that's one of the bigger issues with SIPSN data, as getting access to PHNs or provincial healthcare numbers and using that for the specific link. Is that correct, Stephanie?
Sorry, say that again?
The PHNs, like getting the provincial healthcare numbers within SIPSN, is a bit of a problem, especially at a national level.
Yeah, so we would have to do it on a clinic by clinic basis. So in some regions, you do have to go back to the clinic and get them to generate, you know, a spreadsheet of those patient PHNs because we're not collecting de-identified data. Yeah, so it's a little bit more work to do the data linkage in some regions. Other regions like Manitoba and in Toronto do routine linkages of the SIPSN data to administrative data. But just combining everything, crossing provincial borders is not possible.
Yeah, it's almost like travel nowadays. It used to be a lot easier. But also, these will be discussions that will need to happen with the national data platform, because this is exactly the challenges they're trying to combine. And because Canada is actually 14 healthcare systems, yes, that is one more than provinces and territories we have with their own privacy acts, it gets very, very challenging to combine the data in a meaningful way that can be analyzed. So thank you for that question. You have put your finger on one of the ongoing issues that we have. Okay, so another a little bit technical question is CIPSIN aligning with other reporting groups in setting data definitions? So example, how you define patient panels, case definitions, how you define polypharmacy. So he's just thinking that if the physicians get multiple reports with the same topics but different results, maybe a source of confusion. And I know that that was an issue for cross clinic and setting comparison. So any comments on that? I think the case definitions are published for a lot of the disease algorithms, but what about other things like panels, or even attributing who the main primary care physician is?
Yeah, certainly that that is an ongoing concern. Many EMRs have sort of the concept of a sort of an attachment with that relationship, where this patient is, this is the primary provider for this patient. There are a couple of cases where we sort of do have to calculate it. I believe it's done with the four-cut method to sort of assign them so that we know who to associate the record with. Yeah, and certainly that is a concern that as far as creating panels go, that we haven't waded into too deeply, mainly because there isn't, like you're saying, there's different ways of doing it sort of everywhere, that we don't really have an easy one to align with. I know certainly in sort of administrating the DPT that oftentimes people will say, well, I'd like to see this panel in this way, and maybe in a different province they want something rather different, or a way that it's encoded in the EMR somehow. Maybe they're flagged as active or something like that. So so that is always a challenge to figure out. And I guess the sort of the simplest way that we do it, or at least that we're able to, because we get all the data, we go back as far as it'll go, and we have everything there. We aren't limited in that, we're not only extracting the panel as it's defined by any particular algorithm. It's there so that we're able to later refine it if we do want to map, like if we are matching with a certain other style of reporting. But certainly that is a consideration that yeah, if you have like a provincial reporting body, I don't know where we do that makes reports and things like that to match up with that. The numbers tend to be a little bit different anyway, just with the way it comes out, that I don't know if anybody would really notice. So that's probably an even better, probably something that's very important to pull up, because it isn't always clear that what the comparison is being done on as a denominator.
Yeah, fair enough. But I do know CIPSIN has been really great about publishing a lot of their case definitions. So at least it gives us some clarity on how things are doing. It's never quite as straightforward as, oh, an asthma patient. There's a whole algorithm that's been validated to make sure that when you pick somebody out of the database, that they really do have
I think it's basically asthma. ASTH for asthma. That's how you know they have asthma, according to the case definition.
Yeah.
To a rather good level of sensitivity and specificity.
Yeah, so that gets into whole, yeah, that's pretty much first 15 years of my career, large data set analysis, and how do you do those things? Okay, so the next question is particularly relevant in our, I'm not going to say post-COVID because we're still right in the middle of it, but in the COVID-19 era, because we don't know what is going to be the sequela for people that suffered from COVID-19 and recovered. We're hearing all kinds of things about neurological, respiratory, that it might come back. So this question is really, really relevant. Can we trace and follow a specific patient who have symptoms and see 10 years later what happens to them with like that specific group, for example? So how longitudinal cohorts within SIPSN, to use the research terminology for them. So thoughts on that?
Yeah, so I would say yes, but with quite a few caveats. So for example, so the way that the SIPSN data are, only those who see a healthcare professional will be in the SIPSN data. So if you have mild symptoms and you didn't go to your family doctor for them, we won't have that in the database. The number of years of data that someone has in the database depends on how long they've been seeing their family physician. So, you know, it's perfectly reasonable to expect that some people might have the same family physician for the last 10 years, 15 years. But it also depends on when that primary care practice implemented their EMR. So say they only implemented their EMR system 5 years ago, well, we wouldn't necessarily have all the rest of that data because it's not very easy to integrate historical information from paper charts or even from a different type of EMR system. Yeah, so hopefully, so I would say, yes, we could follow patients over time, but there's just a few caveats to think about.
I agree.
I know that's one. Yeah, sorry, go ahead, Paul.
No, I was going to say, I agree with the fact that, yeah, it's an open cohort. So there's people always entering. And technically we could get 10 years of follow-up if we, if we look back in 2010, and ideally we have data up till 2020. But there are people that entered the cohort in 2015, and we'd have to wait, 10 years from 2015 to get that kind of follow-up. And in terms of, and depends on what you want to look at when you say what happened to them. Are we looking at, did they go to the emergency department? Did they go to the hospital? Did they end up in long-term care? And all of these are different databases that require different linkages to SIPSN. So I guess technically you could do it. It just requires a lot of work to kind of link those to the different sources you want to look at what happened to them.
Yeah. And I know that right now there's a lot of work going on about what we call COVID case definition. So how do you identify COVID patients? Because it's not necessarily there in the diagnosis. So it's complicated, but I think this will be super important for the research, even just a couple of years down the road, because the one thing about COVID is it's not acting like anything we've seen before. So we don't expect it to suddenly fall into standard flu patterns. So that's a little bit disconcerting, and hopefully SIPSN can shed some light on that. Okay. There's a question now about when implementing Connect Care. So we heard from Jill about her involvement in that project, which is quite extensive. So Jill, and maybe others, can you give some insight on when Connect Care is implemented in a new setting? Where's the patient input? Like, do you get input from patients of that clinic? And at what point do you bring in community and patient partners in that implementation cycle, or is it just at the advisory point now? So what's the process currently if you go to put Connect into a new environment?
I'm sorry, I don't know the answer to that.
Anybody else have any insight?
I don't either, to be honest. I don't know how patient partners are included within the Connect Care environment, whether it was only done initially, as Jill had mentioned, or if it's being done ongoing, and if it changes across each site. I assume that it's not, and that it's just a global panel, but I honestly don't know how that's going to be working.
Well, I do know that within Connect Care, there are many what are referred to as area councils. So these would be groups, bone and joint, heart disease, seniors care, that sort of thing, that are sort of working on how Connect Care will be implemented in their specific area. I mean, everybody's information is going to be available to that person, but they deal with sort of the fine tuning in their particular medical area.
Okay, great. So maybe that's a question also to take back and ensure. I mean, Jill has done a fantastic, it was quite an involved and extraordinarily committed process. So I think the question was trying to get a handle on, is there sort of a smaller but important role going forward for patient partners in the Connect project?
And any of these
mhm.
any of these area councils that I mentioned have several patient partners.
Okay, so this leads to the next question. And so just for our audience members who aren't aware, we are living something right now called the sandwich generation. And that's people that have young children, they're the main caregivers for, but they also have parents that they've become the, I would say, the informal caregivers for, and that can often be a very onerous role. Or if you have a child or a grandchild who has a serious health condition, you might be involved in care, and it might be a whole family involved in care. So what is the role for caregivers in Connect? Are they able to access this platform and use
Yes
it?
and no. Okay.
Okay.
As I said, each person will have their own patient portal, which they will be able to access. For children under the age of 18, parents will be able to access their children's patient portal unless the teenager, has specifically said, I do not want my parents to be able to see this. And they have to give a valid reason why that is. For older patients, I was a caregiver of my parents too, and you will, with some, I mean, it's not just everybody's going to be able to go in and have a look. You will have to be qualified and approved to be able to go in and look at your parents or whoever it is that you're caring for's patient portal. And then you will also be able then to add your comments and you know, your views as to what's happening.
Yeah, I think that'll be really critical, especially
It
with
will be wonderful.
yeah, the rise in dementia and all of that. And
Mm-hmm.
and there's usually a lot of people involved in the caregiving, and they don't have a common, I mean, WhatsApp's a great chat messaging, but it's not a great way to keep track of a complicated health profile for somebody you're caring for, and where you might have siblings or other family members or community members even involved in their care. So that's a key thing going forward. Okay. We have had a lot of questions or comments in the chat, so I encourage everybody to read the chat. But we do have a final question, and then I'm going to ask my panelists to give some of the final, a minute or two to share their final thoughts on this topic. And then I've got some housekeeping to close up the session. So this is an Alberta specific question. So could the SIPSN data be merged or utilized with the physician-patient panel reports, which are put out to all family physicians in Alberta by the Health Quality Council of Alberta? They use administrative data, and a combination of that report with EMR data would be a great tool for docs or for doing research or quality improvement. Example, prescriptions written, which are captured in SIPSN, versus what was filled, which is captured in the administrative data. Because we all know that just because you wrote it doesn't mean it got filled. So thoughts on that? So this is combining those two sources of reports, and this would be in Alberta. You guys are lucky to have 2 reports. I don't think in Quebec we have any reports, but what are your thoughts on that?
Yeah, so this is a really great question. And oftentimes we are asked by our sentinels, you know, what is the difference between the reports I get from you versus the HQCA reports? We have had discussions with the HQCA over the last couple of years about potentially doing a combined report. We had started discussions on, what it might look like for an example condition. I think we were going to look at COPD and heart failure and maybe just test the idea of a combined report. So there are obviously some challenges in that we would need to match the SIPSN data to administrative data. And this is always a little bit more complex when you don't hold any identifiers like personal or provincial healthcare number. Yeah, so I hope that that's something we can work towards, because I agree it would be a really great resource for physicians. I guess the other caveat is, SIPSN obviously just includes a subset of all physicians in the whole province. So we wouldn't be able to provide a combined report for all physicians, but I think it's a great idea that we could start to work towards.
That would be really helpful. It's I think people are often surprised to find out that even with EMRs, how much difficulty the clinical team has in accessing that information. And you would think it would be obvious to share that with patients, and that's not obvious, because of course patients are far more invested in making sure their file's up to date and correct, and they'll know when they get the wrong results. So I think there's a lot of things, and one of the reasons we're holding these summer seminar series is to illustrate what's being done out there, but also to illustrate where there are still ongoing work to be done, because a lot of people just assume that, there's a much better communication than there is, the information flows much more freely than it does, that it's captured and usable for everybody on the team. So I think that that's a really key point to highlight, and getting that kind of information back. All healthcare professionals are responsible for something called continuous quality improvement. So they're always supposed to be checking what they're doing in their practice, and if that measures up to the most recent evidence and standards. Well, that's almost impossible to do when you have to go back. You can do it, and they do it, but when you have to go back into a physical chart and hope there's notes on what you're checking, it gets very, very onerous. So it'd be great if this sort of information could be provided more timely feature. So I know in the comments, there's been some comments about how the feasibility of SIPSN and the sustainability of SIPSN and funding. And it is a very, very important tool, both for the clinical context, for patients, and for research. And our network is the end of our funding occurs in September 2021. With COVID, we haven't yet heard news about this, but with our renewal, we're hoping to better integrate the use of SIPSN into the networks across Canada, as they are a key tool for doing timely research. A lot of administrative databases are at least a year out of date. And can you imagine if you were trying to figure out what's happened with care and COVID and you have to wait 2 years to get your data? It's like, well, it's over, it's done. And, survivors are living in Quonset huts. No, sorry. I may or may not watch too many futuristic post-apocalyptic movies, but, we do need timely data for a lot of different reasons, patient care being prominent in those reasons, but certainly to answer important questions. So we have one last question. Will de-identify rule be removed in the future? No, but I'm going to answer that for the panelists. I will tell you right now, no. But there is a lot more innovative ways to protect identity while linking data. There's a lot of stuff to do with big data, machine learning, and block identity, blockchain, using blockchain. So it's not going to disappear, but hopefully it'll evolve. And some of the barriers that have been there for sharing data will disappear. And they've been there for a long time. But I think with the innovations we're getting and the sheer volume of information we have to deal with, this will push the techniques to protect people's privacy while enabling us to actually use the data in a meaningful way. So I'm going to answer that for the panel, because I know that's something near and dear to my heart. All right, I'm going to ask my panel members to take 1 to 2 minutes, short, and share their last thoughts about where they see the future of sort of big data, SIPSIN, or this type of work going. So I'm going to do the opposite order. Jill, I'm going to put you on the spot and ask you to go first, if you don't mind.
Well, big data it's a necessary item. I mean, we need to have research on all kinds of things, and it needs to be accessible. Connect Care will make some research a little bit easier. As I said, I'm really looking forward to it being implemented in my area, which will be in 2023, if our new government doesn't decide that we're not doing this, which is always a big fear.
Thank you. And I think that's, Jill, you raised a point that we try and bring up in all our series. First of all, on the importance of patient partners, also on advocacy, to really get out there and promote what you're doing, what you've found, and why this is so important. Because unfortunately, in politics, as we have seen in the last few years, the squeaky wheel gets the grease. Like, you have to be out there saying, you just can't assume that people are going to do the right thing or the good thing. You've got to kind of hit them over the head with the evidence that this is a good thing to do and it has a lot of benefits. So thank you, Jill, for sharing that with us. Okay, I've actually forgotten my order. Hang on, I got to check something. I think, Matt, you're next.
Sure. So I think that there are several really interesting things that we'll be able to do with big data in the future. We're certainly always working on being able to recode things and to sort of understand the data. I mean, there's sort of two ways that you can approach improving the data that you get out of an EMR. You can either train doctors to put it in exactly the same way every time, which is probably not a reasonable expectation, or you can, as technology improves, things are getting better in terms of sort of just understanding text, and basically taking advantage of technological improvements to sort of get around the issue where the data going in isn't necessarily very clean. So we're always working on ways to improve that, so I think there's great potential there. I think the on the other side, I guess one of the limitations we run into is a lot of it is really less a technical problem than it is a policy and sort of a management problem, because because we have a lot of different there's different privacy legislation in every province. And there are a few very big EMR vendors that control the EMR data to a certain extent that I think there'll be a lot of sort of movement in that area as we sort of proceed to getting big data. But I think the upsides are rather substantial.
Great, and I agree with you. There's, I don't know if any of you have ever used Google Translate. When it first came out, it was a terrible idea. It worked very, very, very badly, and everybody could tell. I live in a bilingual province, and you're like, oh, that's a Google Translate, because it would just be ridiculous and it would make no sense. And now, actually, it's really impressive, and you can even create PowerPoint slides where the PowerPoint will give you a translation of your slides, and it's very good. So this has happened with machine learning. This is with big data sets that continually learn and update. And I really think that, yes, making doctors and nurses and even patients data entry clerks is a terrible idea. We know it hasn't worked. But getting algorithms that learn and can be smarter about extracting the data that's needed from how people put it in, including correcting those 60 different ways of spelling diabetes, which when you add in bilingual province, you can double that, maybe quadruple that, different ways of spelling things in accents or without accents. So I think that I am quite optimistic that we are going to have tools that will really help and will populate these necessary data so that we can get them to the people that need to use them. So I'm optimistic. Google Translate's way better. And there's actually some really, really, really cool So believe it or not, at some point you're going to be able to put an app on your earphones and it will translate a session like this simultaneously into French, and that's not far off. So that's what makes me optimistic. Okay, Paul, some last words you'd like to share with us?
Yeah, sure. Maybe I'll just reiterate what Matt and Jill said. It's an exciting time when it comes to big data in primary care and within our healthcare system. I think we've shown today that CIPSIN and Connect Care are two really great platforms that we can use for research and patient advocacy. And we're just scratching the surface on what we can do at a provincial level or national level. I think if we think about data linkage and the different possibilities of using these sources with other sources, there's a lot of great things that we can do kind of moving forward. And I think that I'm excited to see where that goes.
Yeah, it is. It's going to be very interesting, and I'm glad you could share some of that with you. In another small world, not so pleasant thing, my gran actually passed away from chronic kidney disease. So it's really great to see this progress and insight happening. And that's just one example of many I know that CIPSIN has been providing useful information and data on. Okay, so last but not least, Stephanie, any insights you'd like to share with us? And then I'm going to wrap up the session.
Sure. Yeah, I mean, I agree with everyone. I would also say that one thing I'm optimistic about in the future is maybe moving towards a learning health system. So that's really a cycle of generating health data that's extracted very quickly, cleaned up, and then fed back into the healthcare system to inform providers and patients very rapidly. I think we're still a ways off from that, but I think, with Connect Care and with all the work that CIPSIN is doing, we're really moving towards a more data-driven learning healthcare system, which I would be really excited to see. And
yeah,
thank you.
Well, I want to thank all our panelists for joining us today. This is a completely voluntary use of their time. And I would also like to thank the Alberta SPORE Primary and Integrated Health Innovations Network for helping to organize this and to support this summer series. We are, as a network, as a SPORE, Strategy for Patient-Oriented Research Network, we're actually a network of networks. We are primarily funded by the Canadian Institutes for Health Research, but we all have partner funding, and it comes from a lot of different sources. So I want to thank those partners and the CIHR for their financial support so that we're able to do this work. Jamie, I'd also like to thank Jamie Demore, who's the coordinator, working with me, as well as Stephanie Hindle, who was our summer intern, who's now gone back to school, for helping to organize these sessions and promote them. Jamie has in the chat put the link to our website where you can find the flyer for the next and final summer series, although we are hoping to continue these in the fall. And our last session for the summer will be on the impact of COVID-19 on primary care, and they'll be talking about research and practice innovations that have occurred in Quebec. So I think we're going to hear about 8 different projects or innovations and some of the results for those. Some of them are further on than others. That will be held in French, but the slides will be in English, and you will be able to ask questions in English, and I will be doing the translation. And anybody who attends will be treated to my fabulous franglais with my strong Acadian accent, so you can at least attend for entertainment value. That'll be on August 25th, so next week at the same time. So thank you everybody for attending. Thank you for a lively question and answer session. And I hope to have many of you join us next week. And again, enjoy the rest of your afternoon. And thank you for joining us.
Thank you.